Welcome to this edition of JACC Masterclass series, where we bring you in-depth conversation with global leaders driving innovation in progress in cardiovascular medicine. Today, we're honored to be joined by Dr. Raj Makkar, a true pioneer and world leader in structural heart disease. He's a Stephen R. Corday Chair in Interventional Cardiology at Cedars-Sinai. I'm glad to say he's a consultant editor at JACC, and he's one of the most widely cited researchers in the management of valvular heart disease. Dr. Makkar has performed, perhaps the greatest number of transcatheter valve implementations in the world, including groundbreaking work in what we're talking about today, transcatheter tricuspid valve replacement. He's not only advanced the field through high-volume practice, but also shaped it through leadership in practice-changing research. With over 500 peer-reviewed publications, including those in the New England Journal of Medicine and Lancet, his work continues to define and refine the standards of care. Today, we're going to dive into the evolving field of transcatheter approaches for tricuspid valve disease, a space that's seen remarkable progress in recent years. We'll explore the rationale for these procedures, their history, current evidence, and what's on the horizon. For clinicians, we'll discuss patient selection and some take-home lessons that can translate directly into practice, whether you do these procedures or not. And of course, we'll tap into his unparalleled expertise and vision for the future of the field. Raj, thanks so much for being here with us. It's such a pleasure to have you on.
Thank you, Harlan. You were very, very generous in your kind introduction.
I only tell the truth. I only tell the truth. So let me just jump in here. So the tricuspid valve has historically been referred to as a forgotten valve, although I've noticed that some people in the field actually feel like, no, it's not forgotten. We've always known about the tricuspid valve and focused on it. But as a target for intervention, it's still relatively new on the side of thinking about transcutaneous approaches. Can you sort of walk us through the evolution of your understanding and where we are with regard to tricuspid regurgitation and the unmet needs that sort of brought the transcatheter approaches into focus?
Yeah. So I think, we all know, or we all knew that there was a lot of tricuspid regurgitation. It was right under our nose. And then there were some observational studies that actually showed that tricuspid regurgitation is associated with worse outcomes. And I recall, a few years ago when we used to be doing mitral TEER procedures, we would see tricuspid regurgitation in these patients. We were using the MitraClip device and we would fix the mitral regurg and we would see tricuspid regurg. And actually slowly what we started doing was, on our way out, as we would call it, we would actually, after we had done with the mitral valve, we would start tackling and doing a TEER procedure, transcatheter edge-to-edge procedure, using the off-label use of the MitraClip device on the tricuspid side. And we started to see some good results. The procedures were not simple always. The imaging had not evolved the way it actually is today. But nonetheless, we actually would see, some of these patients actually getting good results with the TEER device. So I think that was the beginning of transcatheter procedures. Of course, putting, a valve in a prior surgical valve in a tricuspid position is an easy, category of procedures, and we were all doing that. But that was the beginning. And then what we saw was that in the clinic, we started to see patients with tricuspid regurgitation, independent of mitral regurgitation. And we had gathered some early experience, and our European colleagues were also doing that, the TEER procedure in registries and in an off-label fashion.
So let me just stop you 1 second. A lot of people here will be following the field sort of tangentially. Of course, they're all the structural experts, but there are a lot of people who are watching this at distance, even hearing terms like, TEER and the edge-to-edge. Can you just explain that a little bit? What does that actually mean when you're talking about TEER procedures, this edge-to-edge thing? What is it exactly?
So it started with a surgical procedure by Dr. Alfieri. So it was actually what Dr. Alfieri saw was that he could take certain categories or certain pathologies of mitral regurgitation, and he could actually bring the two leaflets together in certain parts where there was regurgitation, and he could actually reduce the mitral regurgitation. So that is
Or
how,
was this the Alfieri stitch was,
that's correct. So it was the Alfieri stitch. So TEER procedure,
and just to go for that for a second, I mean, what was the Alfieri stitch? What was a stitch exactly that
so
solved the problem for the regurgitation?
yeah, so basically, when Dr. Alfieri saw that there was a certain diseased segment in the mitral valve that was prolapsing, for example, he would bring that portion of the mitral valve and stitch it with the posterior leaflet. All right. And what he observed was that you can reduce or dramatically reduce tricuspid regurgitation. And then other people had this idea, if Dr. Alfieri can do this surgically, why can't we do this, using transcatheter techniques? And of course, there were earlier devices which actually did use a stitch, but it wasn't very successful. In fact, I was involved in one of those devices called the Monarch device, where we would actually go and put a stitch, but the stitch was not durable in some patients. It broke. So, very quickly that procedure was abandoned. But then the clip, using the edge-to-edge procedure using a clip was a durable procedure. That's a device that Abbott sort of, brought it to the market. So
What always amazed me about this was when I first started hearing about this, I thought, well, wouldn't you be causing a little bit of stenosis because you're causing obstruction to the forward flow also as you're kind of constraining the movement of the valve, and yet this didn't happen, right? I mean, it wasn't really.
So you're right. I think therefore, if you just put this in a small segment and you have open orifices on both sides of the clip, then you're okay.
Yeah.
During the diastole, there is enough room for the blood to go from the left atrium into the left ventricle. But when you start having multiple devices, you do start to impact gradient. So in some of the worst cases, you might actually cause mitral stenosis.
Mm.
And often the criticism of TEER procedure, transcatheter edge-to-edge repair procedures, more commonly on the mitral side, is that you may be replacing one disease with another.
Mm.
If you use multiple devices. So we are very careful, and indeed, we've actually done some analyses from the mitral TEER registry, the real world registry, in almost 20,000 patients, where we actually showed that gradients are important, and your best outcomes are when you have less than mild mitral regurgitation and gradients less than 5. So, there is a penalty to pay if your gradients are high in terms of mortality, in terms of rehospitalization for heart failure in this particular analysis. So,
And just to go back to this edge to edge, why is it edge to edge? Because it's
it's edge of the leaflet.
edge of the leaflet. Okay. Yeah.
So it is edge of the anterior leaflet to the edge of the posterior leaflet. Okay.
Yeah.
So, and a lot of times we go beyond the edge. We are not just restricted to the edge. We almost go to the base of the leaflet to get a good grasp. But that's where the procedure terminology sort of stems from. So I think inspired by the Alfieri stitch to the mitral valve, and then we couldn't do it in the mitral valve, and we saw it in the tricuspid valve. So we started to use it in an off-label fashion there, and we also found good results, in the tricuspid valve. So ask me more.
Well, so I mean, it's a really fascinating thing. So, as you've been seeing this, what really makes this transformative for patients, especially those high risk for surgery? I mean, I think just for you to expand on why this is, creating so much excitement, right? Because you actually are doing these procedures. Next day, people are coming out in a hemodynamically very different state than when they came in the lab. And I'm just thinking back, it wasn't that long ago, if someone was facing torrential tricuspid regurgitation and having symptoms associated with it, especially if someone was old, they had comorbidities, we were loath to send them to surgery. This was kind of game changing for a lot of those patients that you must be seeing. I mean, was that your experience?
So it is game changing for a lot of patients, but Harlan, our expectations were very high because we were all on a sugar high from the TAVR procedure, where, of course, after the very early experiences, we developed this procedure. People started going home the next day. The mortality was less than 1%. There was dramatic reduction in mortality and rehospitalization at 1 year. And there were massive improvements in KCCQ scores of almost 20 points. That's what we saw with TAVR. And of course, we started with the highest risk, and then we went to the point where actually, it became de facto the procedure of choice over surgery, even in low-risk patients. So I think that's where we started from. And our expectations, we thought we are going to have such dramatic results from tricuspid regurgitation, treatment with transcatheter therapies. So I think what we observed in clinical trials, both that were done with TEER as well as with tricuspid valve replacement, is that yes, there are improvements, but we were a little bit disappointed. There were no improvements in the hard endpoints of death or rehospitalization. And primarily, what we saw was most of the benefit was actually driven by the improvement in functional status, improvement in symptoms, and improvement in quality of life. So that is where we actually saw the biggest advantage. So I would say, as I do these procedures, it is amazing to see some patients, who we would have called cohort C, in cohort C, which means they're not good for anything. And some of these patients actually improve dramatically.
So these are patients who are high risk for any kind of procedure because they're frail.
That's correct.
Comorbidities and so forth.
So that is correct. So Harlan, you're right. I think it's important to point out that the patients that went into these studies were actually old. The typical age, whether you look at the repair triluminant, whether you look at the TRISCEND, which was the randomized clinical trial that was done with replacement, was almost 80 years. You're talking about 79 years of age being an average age. Most of these patients have lots of comorbidities. In fact, so, most of these patients are in class 3, class 4. Almost 90% of patients have atrial fibrillation. 20% of these patients have ascites, renal dysfunction. So this is a patient that is very rich in comorbidities. So these are not patients that the surgeons would actually like to touch, and that's for not without a reason. I mean, when you look at the outcomes of surgery in these patients, they were pretty dismal. In fact, you're talking about a mortality of 10% in patient cohort that are actually less sick compared to the patients that we have treated in, the transcatheter therapy trial. So these patients are not good candidates for surgery, and that's how they made it to these clinical
So just
trials.
to juxtapose this a little bit, when you're talking to patients, what do you tell them about the complications, the risks associated with these procedures? You're consenting them, and as you're looking at your experience, and was one of the highest, maybe the highest volume provider in the world. What are you seeing in terms of complications and risks associated with these procedures on the transcutaneous side?
So what I tell my patients is that we are early in the game. All right. So despite the fact that we have these devices approved, which is we are early in the use of these devices. But nonetheless, I tell them that there are two ways of treating them right now broadly. One is using the edge-to-edge repair technique or repair technique, and the other one is actually the replacement technique. I tell them that the reduction in tricuspid regurgitation is somewhat less robust with the repair technique, while with the replacement technique, I can really dramatically reduce the tricuspid regurgitation. But I also tell them that the safety of the repair is much more. So it is much safer procedure. You're talking about mortality from a tricuspid repair procedure or tricuspid TEER procedure less than 1%. You're talking about pacemaker rates that are practically nil, compared to the tricuspid valve replacement procedures, where the procedure-related complications of bleeding occur about 10% of the times. where you have about 3% cardiac mortality and you have about 25% need for a permanent pacemaker. All right. So I think that, so those are the important issues right now with tricuspid valve replacement. While it is dramatically effective, and it is very dramatic actually to see tricuspid regurgitation disappear from what is torrential or massive to practically nothing, within minutes of deploying this, there are safety issues, which I'm hopeful and which I tell patients that I think that our safety has become better, as we have matured in our experience. But nonetheless, there are actually some important differences. So I think it is not unreasonable to follow the paradigm of, if you think you can get a very good result, with the TEER procedure, to go down the TEER path first, rather than actually subjecting some of these patients to tricuspid valve replacement. But I think it is also important to remember that once you have done a TEER procedure, you've changed the anatomy of the valve, and that makes them less suitable. I wouldn't say that they are not candidates, but the situation is then very difficult. They would routinely be considered as not candidates for tricuspid valve replacement. So these are the trade-offs. And I take into account, clinical factors also in addition to anatomical factors. So if you've got a person who cannot take anticoagulation, tricuspid valve replacement is out. If you have a patient who has a pacemaker in place or leads in place that make TEER difficult, then you're much more inclined to go towards tricuspid valve replacement procedure. So I think it's a combination of anatomical factors, clinical factors, and of course, patients and the individual experience that sites and operators have.
So I think this is a really important point, and a lot of people listening here are going to be people who are going to be referring patients, and so this patient selection issue, I think, is so important. And of course, it's happening, as you're suggesting, on two levels. I mean, there's a level of the structural interventionalist who's actually trying to decide, what recommendation to make, and what might be the balance of risks and benefits, who's going to benefit. There's the person out in practice who's trying to decide who should I be sending to a structural interventionalist? Because, and I will say, when you're in practice, you kind of don't want to embarrass yourself by sending people who aren't candidates, and so you want to be sending people who are legitimately could be considered for these procedures. What do you're teaching a lot of people all the time about this. What are you telling people out in the field who are seeing patients who may not, again, have experience directly with the procedure, even might be at places that don't offer the procedure, so they're needing to refer them to other centers for people to get consultation? What are you telling them about the triggers that should get them thinking that this is someone it's worth having the conversation? Not that they're committing them to the procedure, but that it's worth, in other words, your time, worth setting up an appointment with you or one of your colleagues, to be able to start talking about whether this is beneficial or not. How are you telling people to think about this?
So I think that, of course, you don't want to discourage your referring doctors from sending you patients, but I think that it is reasonable to say, I think if your patient has severe tricuspid regurgitation and they're symptomatic, for sure, please send them to the heart valve clinic. And I think there will be, the heart team approach will appropriately triage these patients. I would make the argument that if patients have severe tricuspid regurgitation, and even if they're not symptomatic, it is okay to send these patients to the heart valve clinics, because I think it is important for us to understand how these patients do. So, these patients might come to us and we may decide not to do an intervention at that time, or we may decide to, based on, how their anatomy is. But I would say that if they're symptomatic, definitely send them. If they have moderate tricuspid regurgitation, I think you can manage those patients, locally, I don't think those patients actually need to come. And we need to understand the natural history and we need to learn more. So I think when you send these asymptomatic severe tricuspid regurgitation patients to heart valve clinics, I think we will actually, because some of those studies need to be done, about the natural history of severe asymptomatic tricuspid regurgitation.
So,
And
so let me just jump in for 1 second, because you're using this term heart valve clinic, and maybe you can explain what does that mean? Do you mean one of the places in the country that's actually doing structural interventions? And by the way, how many are those in the whole country?
No, I'm talking about.
What is a heart valve clinic?
Okay, so for example, we at Cedars-Sinai have a very multidisciplinary. Every Wednesday for aortic cases, we have a surgeon, an interventional cardiologist, a imaging person, and a couple of general cardiologists who will actually get together and talk about aortic. On Thursdays, we will have all of these people plus a heart failure person, actually. So we go through these cases.
You mean that you have it like a tumor board? I mean, if I just make the analogy to cancer, you're all sitting as a heart group, but you're not seeing this patient. You're having somebody presenting the patient to the group who, and one of the members of that team has seen the patient or knows about the patient. That's how it works.
Yes. So basically, when I see a patient, most of the times my surgeon will see a patient at the same time. But then we will bring these patients to the heart valve, clinic meeting, essentially, where we have other people. So where we have the echocardiographers, a CT expert, a heart failure person sitting there. And I think that aortic has matured. We could technically, do that on the fly and on the run very fast. Mitral, we are still struggling because we don't have the best devices in terms of treating these patients. But I think this process is going to be very important for the tricuspid patients. So I think we are all learning, and I can go and do a valve replacement in a patient in 20 minutes, but I'm not sure if I did the right thing. You know what I'm saying? So that decision, whether or not we should do it, and
what happens when you and the surgeons disagree? How do you just go back to the patient and say, well, there's two opinions, or how do you do that?
I mean, I think for tricuspid, fortunately, there are very few disagreements because most of these patients, surgery is technically not the standard of care. Less than 0.5% of patients who have severe tricuspid regurgitation are being treated with surgery. And hence, when we did the pivotal studies, the comparison was not to surgery, the comparison was to optimal medical treatment. So I have to say, the surgeons are very happy. And once again, I want to point out that the turf battles have almost disappeared because we do these procedures together. So even when I am doing a tricuspid valve replacement and I have my interventional colleagues, the surgeon is around. He may or may not be in the procedure, but he is around and he's part of the team that made the decision to go forward. Now, there may be, the agreements can occur, for example, when you're dealing with a bicuspid aortic stenosis, which is very different. That's we need more evidence there, and of course, hopefully, we'll do more clinical trials that will actually help. So,
when you're in these meetings, you're also talking about, should it be TTIR or should it be TTVR? Should you talk about
that's correct.
I mean, you've got options, right? You're trying to.
That's correct.
And evidence is still accruing.
And I have to say, importantly, our biases come into play, and our experiences come into play, right? Because early on, we were trying to figure out, is it even worth treating tricuspid regurgitation, right? So I thought, okay, maybe what we need to do is use a technique that wipes out and eliminates tricuspid regurgitation, and then we'll find out. But it wasn't so simple, right? We had early complications because the technology was still not, completely mature, and our learning curves had not matured. So I think that we are at.
When you say those complications, like what would happen?
I think we're talking about pacemaker requirements. I mean, a 20% need or 25% need in a randomized clinical trial for pacemakers is not trivial. In a pacemaker, naive patient. When you look at the entire cohort of patients, the need for pacemaker was about 15% because 40% of the patients already had pacemakers. All right. So, but that's not trivial. The complications that we had, for example, even though it is small, the rate of conversion to open surgery 1%, and 1 to 2%.
So, I mean, and that's relative, those are low numbers, but yeah, for the person
Yeah,
it happens
but,
to, it's terrible.
But I think we should not forget, Harlan, in the early days of TAVR, the 30-day mortality in TAVR used to be almost 5%,
Yeah.
and the stroke rates were 5%.
Yeah.
Okay, so look where we are today now.
Yeah. Yeah.
Less than 1% mortality, with the TAVR procedure. So I don't think it's amazing how rapidly we went to a randomized clinical trial. If you look at the story of tricuspid valve replacement, it's fascinating. We did not even have a dedicated device for tricuspid valve replacement. The EVOQUE valve was actually designed for mitral. And some good people in Canada and Europe actually did some of the earliest cases, compassionate cases. And then we got involved in the United States, in the EFS study, which enrolled so fast. Okay, and then we very rapidly went to a randomized clinical trial. In fact, it was amazing how fast. So a device that was not even invented or designed for mitral, for tricuspid, was used in the tricuspid position, and we are done with a randomized clinical trial. So that's essentially a first generation device. I have complete confidence that the safety of these of tricuspid valve replacement will dramatically improve in the coming months and years. And then I think it'll be the right time to actually then compare tricuspid valve replacement versus tricuspid valve repair in a big subset of patients who are candidates for both. There are some who are not candidates for one or the other procedure, but then I think that will be the right time to compare repair versus replacement.
Could you just touch for a moment, because we were talking about this patient selection and the issues that you're considering, maybe on the anatomic complexities, RV function, comorbidities like AFib and pulmonary hypertension. How do these things play into your decision-making around recommendations and in the outcomes of the patients? Because obviously there's looking at the severity of tricuspid regurgitation and the symptoms, but those are just really two pieces. But when you're a structural interventionalist, you are thinking about these anatomic pieces and the RV function and so forth. Can you just, as a master in this, take me through how you are considering this when you're looking at a particular patient's information?
I think it's easy to make that recommendation when you are talking about anatomical factors. If you see a patient, because I think one thing that we forget is tricuspid regurgitation is a very heterogeneous disease, right? There are broad buckets. There is the atrial functional, there is the RV functional regurgitation, where the RV is very robust, and it's just the atrium that is dilated. And then, of course, there's a whole new emerging categories of CI, a lead-associated tricuspid regurgitation. So, I mean, if there are, and tricuspid valve always doesn't have 3 leaflets. At times there are 4, there are even 5 leaflets occasionally. You know what I'm saying? So I think, so when you have these anatomical complexities, it is easy to say that valve replacement is somewhat agnostic to the anatomical complexities, and let me lean towards and let me recommend tricuspid valve replacement. So whether it is leads in place, whether it is, though more and more we are learning that actually you can do tricuspid valve repair, in fact, in patients with leads, and that's emerging data from the TriLuminate trials and also from the real world registries, actually, that, for example, one of the registries in the current issue, the tricuspid issue, is the PACE registry, which is from Europe, and they found some correlation between presence of leads and residual tricuspid regurgitation. So all of that is evolving, but or a carcinoid patient, for example, who has his leaflets stuck stiff and down, or a rare rheumatic
Mm.
case that comes across. You know what I'm saying? So I think those are all candidates, or patients who have torrential tricuspid regurgitation. Okay, so I think there I'm much more inclined to recommend tricuspid valve replacement. But when the coaptation gap is not very wide, when the jets are more localized, either in the anterior septal commissure or even posterior septal commissure, and when you look at the echo and you think you can actually get a decent result, um, I think it's reasonable to go ahead and do TEER. My biggest hesitation is if I do TEER and if I don't succeed, will this patient be left in the cold, or can we still do a valve replacement? And we've done a case with, where we have done a tricuspid clip before, and then we went ahead and did a valve replacement anyways because the clip was actually in a commissure, and we were able to do it successfully. But I think that's something that always is at the back of my mind.
Maybe you can just take a few minutes just to give us a sense of these research frontiers you think. We've touched on some of the unanswered questions, I think. We need more trials and so forth. But how about what do you see coming down the line in terms of device innovation? What do you think we're going to see in terms of long-term outcomes and the potential for earlier intervention? Is JACC also going to come up with tricuspid valve like we're talking about it for TAVR and so forth?
Yes. So Harlan, I forgot to answer your previous question completely because you'd also asked me about some of the other situations, for example, RV function. And I think RV function, pulmonary hypertension, these are open questions. And the true answer is we actually don't know. Yes, if somebody has a really bad RV function, I don't want to do replacement because we've had patients who had moderate to severe RV dysfunction or moderate, and these patients can fail their RV and they often struggle, and you got to support them with dobutamine for a few days. So I think that's important. About LV dysfunction, patients with worse LV, really bad LV functions were actually excluded in clinical trials. But now we are beginning to do them, in registries. And we will actually learn a little bit more, But I think that when you have bad LV or RV function, perhaps repair is better than replacement. When you have severe pulmonary hypertension, the safety of these procedures is not established. But when you have pulmonary hypertension that is moderate, we've used tricuspid valve replacement, and we've also used tricuspid valve repair. Repair does seem a little bit safer, to do. But I think that's an area where we actually need a lot more information. So coming to your next question, which was about what are the research frontiers, right? I think, so the question in my mind is, where is the big evidence gap? I mean, is it true that there is no benefit in terms of reducing hard endpoints based on one-year outcomes, based on studies? It seems that way. But I think if you go back and look at the COAP trial, for example, we didn't see all the benefit at 1 year. In fact, the MitraFrance study at 1 year was actually negative. Of course, there were different patients. So we need long-term follow-up. And I wish, the TRISCEND study was 2-to-1 randomization, and it allowed crossover at 1 year. And even if it didn't, the fact that the device is approved commercially, not many patients who didn't get the device would want to sit at the sidelines. All right. So we've almost lost the opportunity to find out. And I lament that fact. I wish the TRISCEND study was a bigger study, not 450 patients, but maybe 600 patients with a 2-year follow-up, with no crossovers allowed. Then we would have really found out, is there a real benefit in terms these therapies, with the hard endpoint. So where do we go now, right? I think, do we restart? Because now we are back, so how do we, and do we go to specific buckets of tricuspid regurgitation? Because this is a very heterogeneous disease. The patient, as I mentioned earlier, who has got a large right atrium and a robust right ventricle is very different than the patient who's the other way around, who's got a dilated right ventricle and a dilated right atrium. So I think that it may not be unreasonable for us to do studies in specific categories of tricuspid regurgitation. So I think it will be very good to do patients in atrial functional, tricuspid regurgitation. We need to do similar studies in ventricular. Every day there is a debate in the clinic, in the heart team, when we have a patient who's got lead across the tricuspid valve and has tricuspid regurgitation. There are people who want to remove the lead and then do tricuspid repair or replacement. Others don't want to. I think we need a randomized clinical trial there, that says, okay, you can remove, because the mortality by removing a lead is not trivial,
Yeah.
So I think, those clinical trials need to be done. Pulmonary hypertension is another area. So I think whether or not, how do we treat these patients is also another important area. So I think there will be newer devices. There are newer valves coming. There are at least 7 tricuspid valve replacement therapies. So we'll actually be getting EFS data on a lot of them. And then, of course, we'll be able to compare different valves.
Are you running into any problems getting coverage for these procedures? I mean, are payers saying you need more evidence? I mean, this, of course, there are naysayers anyway who say without the hard endpoints, we shouldn't be doing so many of these. Of course, patients who experience marked benefit, are saying positive things. Some people are saying, you really need sham studies to be able to understand this. Those are enormously difficult.
I think you brought up a very important point, right? All these benefits that we are seeing are just in quality of life. And, these may be related to the biases, of course, of the patients. Patients who got the device generally feel better because they got something. And of course, they are followed much more closely. So I think the area of sham studies is an important one. And I think it also needs to be, carefully looked at. So I think I will not be surprised. In fact, we've been talking about, designing studies with sham control. So I think we will be moving in that direction to proof. I think Orbita has actually laid the framework, for that in patients with coronary artery disease. So I think there is the Relieve heart failure, was a sham control study, presented by Greg Stone with intra-atrial shunting. And it was very interesting to see how patients, even who did not get the device, but they were sham controlled, actually ended up improving in their KCCQ scores by similar numbers, about 10 points. But I think there may be a component, but I think to the naysayers, I would say for now, it is important to provide coverage while we are trying to sort out things. And I think we can make the argument that even though these were not blinded studies and not sham controlled studies, if you look at the magnitude of improvement, when you see a 12 point increase in KCCQ at 30 days, which continues to increase over a period of time to 1 year to almost 19 points. So not only the magnitude, but also the durability.
Yeah.
To some extent, what you might want to call the dose response. The patients who had more reduction in tricuspid regurgitation had more improvement in KCCQ. So these are all indirect pieces of evidence that suggest that this is probably a true effect. And I don't think we should, I think we should be critical, but I don't think we need to be overtly harsh, in terms of criticizing just the improvement in KCCQ and other health status benefits.
Well, and I'll say compared to a lot of the other areas of the device world, evidence is accumulating. I mean, there's a lot of places in the device world where, Impella, where, people weren't running trials for a long time. We finally did get one recently, but it's taken a while. This community in structural has really embraced the knowledge generation. It needs to keep going. As we sort of get to the end, and this has been a wonderful tour through this remarkable field, what are some sort of take-homes for clinicians? Our field has become so fragmented, cardiology, so people go to their own meetings and so forth. So it's like, of course, the structural people have been following this very closely, but for a large segment of the cardiology audience, they're seeing it from afar. And, are there any take-home points you see from where we are right now when we think about tricuspid interventions that all cardiologists, general cardiologists should be aware of and paying attention to? Are there any take-home points for them?
So I think I would say that I know we grew up on the primary endpoints of death and stroke and rehospitalization primarily, but look at the patients that are coming to our clinic, the 79-year-olds. When I talk to them, not many of them say that they want to live longer, not all, but all of them say they want to live better. So I think that quality of life is a very relevant metric.
And by the way, if you help them live better, then they'll want to live longer.
That's correct. So what I'm saying is that, most patients want better quality of life, and they want to be able to take care of themselves, and they want to be able to do day-to-day activities independently. So I think that this is a relevant, endpoint, and it's a very relevant thing to treat, right? We do more than 1 million PCIs in the United States, okay, because it improves quality of life. And I think to just say that, that is not relevant in patients with valvular heart disease is not fair. So I think we will learn. So I think number one, to the cardiologist out there, I think the time when we used to simply neglect tricuspid regurgitation is probably gone. So I think we need to be more mindful of tricuspid regurgitation like we are of aortic stenosis and mitral regurgitation. That doesn't mean that every one of these patients needs to be intervened upon by devices. I think there are also drugs that are being refined, that are being studied. For example, SGLT2 inhibitor, there are a couple of studies that are ongoing. We don't know what the role of ARNI is in patients with tricuspid regurgitation. So I think we should be sending these patients to good heart valve clinics so that they can be properly assessed and then they can be properly triaged, whether they should be treated conservatively or with devices, and there are a number of clinical trials right now that need to be done so that we can fill up those evidence gaps. So we will need our general cardiologists to be more mindful of that, and they need to be sending these patients.
So as we just get to the end, I just want to ask you on a personal reflections. You've been at the forefront of this field for years. You're one of the hardest working people I know. You're so dedicated. I have had the pleasure of being on consultation with you with a joint patient and sort of being able to see not only your deep knowledge, but your empathy, your ability to communicate with them, your caring that you convey. I just wanted to ask you, as you get through this, you've done this for a while, what's something that continues to inspire you most in this work? And what advice would you offer clinicians and researchers who are thinking about entering the field of structural heart disease? And what do you say to folks who come to you for advice around that?
When I was a fellow, Harlan, the stents were approved, and I used to see pictures of these courses that Andreas Grunzig used to put, and my mentors would show, look, there I am in that course, or whatever the case is, and I used to feel a little envious. Wow, it was so amazing. It would have been so amazing if I was there at that time. So I think when the valvular heart disease, the structural intervention, the whole field started, I realized it was such an important time to be there. So I think, while I missed the PCI revolution, it was fantastic to be there when the whole TAVR revolution was starting. All right. So I think to have come from a place where we used to do 1 or 2 TAVRs and it used to require massive, organization, to doing 6, 8 TAVRs in our lab, occasionally 10 TAVRs in our lab between different operators. I think it's amazing how far we have come. So I think if we can, and there is a lot of, while aortic stenosis is done, aortic regurgitation is still work in progress. There is still, we've done some early studies. I think mitral regurgitation is wide open, okay, because there are lots of patients who are not good candidates for TEER, and we have a number of devices. There are anatomical challenges that need to be overcome there. And I think tricuspid regurg, we had the tools, so we applied them, but we don't understand the disease very well. So I think we were a little bit premature. So I think there is a lot of work that needs to be done. And there are a lot of New England Journal of Medicine papers and JAMA papers. I would tell the young, my younger colleagues that there is a lot of academic spoils still to be collected. And of course, there is nothing more important than when a patient comes to you, and feels so much better, and they are a different person. All right. So I think that is what inspires us, right? What, Harlan, our patients keep us going. They, when you see them improve, and of course, there are times we fail. There are times we have complications. As long as we learn from them and apply to make the next procedure better for our patients, I think it's worthwhile.
Raj, I count myself so fortunate to have you as a friend, a colleague. You're helping us at JACC. You're making such contributions, of course, in structural heart into the patients. It's been a privilege to learn from someone who's shaped the field so profoundly. Thank you so much. And for our listeners, this has been a masterclass on transcatheter approaches to tricuspid valve disease. And we've been very fortunate to talk with Dr. Raj Makkar here today. Stay tuned for more episodes like this in the future, but this has been a very special one. And thank you so much, Raj.
Thank you, Harlan.